I'm a gynecologist, obstetrician. I'm founder of this hospital. I've been there since it was started. I work hard, I just deliver babies. I'm a delivery boy. I came back from England being a specialist. I had no access to especially hospital, private hospital services. So we had to build our own hospital. You know, those days are apartheid days. Patients were allowed in the private hospital, but I was not allowed to go and see the patients there. So I was disadvantaged in that way. And the old visionary doctors like Dr. Mutlana, Dr. Mokhesi, thought of an idea of having a black hospital. That's about 30 years ago. And this hospital, they went looking for money and they built the hospital. It has been flourishing since then. There are people who didn't believe that a private hospital could start. But there was one particular doctor, I must mention him, Dr. Mutlana. He had that vision that one day things will change. It has been expanded by clinics and Dr. Matsike to what it is today. It's one of the best hospitals in Johannesburg. Now there's an avalanche of black doctors of all disciplines. I'm vindicated, I feel vindicated, I'm excited about that. There's more staff, there's more nurses, and it's a happy environment. High-class theaters, second to none in this country. You need to have special facilities for black people here. So this place grew. They saw the potential of this place. It can still, it has a capacity, of serving a community of 4 million people. It hasn't reached its capacity yet.
Thank you very much. And that's a nice clip there about what Black excellence means. And that's what we're all about at clinics, but we're just not there. From Black excellence would mean every South African, from every race, you're welcome to be part of the clinic's health group and also to be working in our facilities. And we are glad that we are fulfilling that mandate of working in the previously disadvantaged communities, both in the townships and also in the city centers. And that's one of our top specialists that we have just also befitting that we've got a topic that touches on the same subject of obstetrics and gynecology this evening. And we just want to welcome you once more for joining us at this webinar. And it's great to see the support that we are getting from the colleagues who come from across the medical disciplines, not only the medical specialists or GPs, but we also have got colleagues from other allied health professions and nursing profession. And we are glad that you support these webinars. And we also want to encourage you to partner with us. And if you've got any speaker that you reckon is someone that is worth listening to, or listening to the presentations or sharing their presentations, please do get in touch with us. And we are glad that even this evening, MSD has partnered with us once more, and this relationship is growing, and we just don't want to limit it to MSD. If there's any other pharmaceutical company that also has access to speakers of note, like we have tonight, please do contact us and we'll work with you and showcase what they have, because we are all about improving clinical practice and improving and promoting research and knowing what is there, the latest advances in medical research we also want to share on this platform. So know that these webinars are also CPD accredited, and we will request that you send us your details, share your information so that we can then upload information for those who are with the HPCSA. We upload this on the HPCSA through a partnership with SAMA that will then help you to get your points with other professions, or regulatory bodies also do the same thing. We share that information that you can get certificates or of attendance for that matter. And these webinars are recorded live on YouTube. So if at any time you want to listen or watch the previous presentations, you're at liberty to go to our YouTube page. After the webinar, on the following day, we send you a request for you to fill in a questionnaire and give us information about how you find these webinars. But also at the same time, when you get a link to the YouTube page, please like us on YouTube Clinics Health Group, and you'll get reminders about the presentations, and you can also access these presentations at any time at your leisure. So without any waste of time, I'm going to request Thando Akano from MSD, who's the medical advisor on the vaccines unit section at MSD, to do the introduction, because we just quite glad that she was able to help us to get Dr. Trudy Smith, who's going to be giving a talk to us. So now I'll leave it up to Thando to do the introduction. Please, colleagues, make sure that when you join the webinar, mute yourself, switch off your video at all times, and wait until the end of the presentation, because we've got the Q&A at the end. But you can post your questions anytime during the presentation on the chat group. Thanks, Thando. Welcome once more. Say that you're becoming a co-host.
Hi, thank you, Dr. Vila. Can you hear me?
So I can hear you loud and clear.
Okay, perfect. Okay. Thank you for that introduction, Dr. Vila. So I'm just going to, I have the pleasure of introducing our speaker today, who is Trudy Smith. It's Dr. Trudy Smith. She's a gynecology oncologist and works at the Wits Donald Gordon Medical Center, which is the first South African private academic hospital. She's also a senior lecturer at the Witwatersrand University. And she actually, you know, I could go on about all the things that she has done, but I think the key thing that she wanted to share is that she has a passion for cervical cancer management and prevention, and to drive the elimination goals. So without wasting any more of your time and going into her CV and all of the stuff that she's done, I would like to introduce Dr. Trudy Smith. I also like that she's a teacher, so this means that today we're actually going to learn quite a lot from her. Over to you, Dr. Trudy.
Thank you very much for inviting me. I'm truly honored. So I'm going to share my screen with you. I hope I get this right, and I hope that load shedding allows me to do this. Can you hear me and see me?
Yeah, we can hear you. We can see you.
Okay, so thank you so much for the invitation. And I was asked to speak about HPV disease and its prevention. And I kind of kept it simple because there's a few things that I want to drive home to us as we continue in our presentation. Let me see if I can forward this. Okay. So the first thing is I've got lots of disclosures, but the most important is that this presentation is really based on my clinical expertise, research, and experience, and in no way represents anything that MSD does. So I'm going to discuss HPV disease, some South African epidemiology, something about screening, prevention, and the types of vaccines that are available. So this gentleman, his name's Dr. Harold Zuurhausen. So he, in 1976, published the first hypothesis that human papillomavirus played an important role in cervical cancer. And in 1983, he identified HPV 16 and 18 as causes of cervical cancer, or part of the causes of cervical cancer, for which he won a Nobel Prize in 2008 for the proof that cervical cancer is induced by a virus. And just to say that it's not just HPV alone that is important. It's more, I want you to keep in mind the word persistence. It's about the HPV hanging around, because I'll show you that all of us are going to have, as women, over 80% of us will get HPV whether we like it or not. The only way to stop getting HPV is to never put anything in your vagina, which is almost impossible. But there certainly are potential cofactors that are involved. And some of those cofactors is co-infection with other STDs puts you at risk of acquisition of HPV. We know that diet and perhaps genetic factors that we really don't know about yet, but we are starting to learn about them, might play a role in us not being able to get rid of HPV. But more importantly is smoking. I can't begin to tell you, if I take a history, patients who are smoking, patients who are immunocompromised, and it does not have to just be HIV. It can be things like, I recently reviewed all the literature in patients with rheumatoid arthritis and patients with immune deficiency syndromes who are now put onto biologics are at extreme high risk of not being able to get rid of HPV. There was some literature on oral contraceptives, but the thing on oral contraceptives is not necessarily that they prevent you from getting rid of HPV, but in fact, women who use oral contraceptives are less likely to use barrier methods, and for that reason might be at higher risk of constant HPV exposure. So HPV infections are very common, and the cumulative risk of acquiring HPV with only one sexual partner, I want to emphasize this, one sexual partner, because so many of us practitioners stigmatize it, and we tell our patients, we don't want them to believe that infidelity is involved or anything like that. Basically, it's a skin-on-skin contact that gives you HPV. It is not a sexually transmitted disease, but rather let's call it a sexually acquired disease, because the skin that meets the skin, unfortunately, invariably is a penis. So that's why your risk is higher. And even after one sexual partner, 46% of women will acquire an HPV. And that risk continues throughout a woman's sexual lifetime. And up to, like I said to you, 80% of women will acquire an HPV in their life. But it's your ability to clear the HPV that is important. So transmission or acquisition is obviously through sexual contact, but it doesn't have to be through penetrative sex, but it can also be through manual genital, oral genital, genital. And while we know that the proper use of a condom decreases the risk, it does not fully protect you against an HPV infection. I tell the registrars you have to put a condom from the top of your head down to your toes and tie a knot at the bottom so that you don't have any skin contact, and that's absolutely impossible. So what about non-sexual routes? There certainly is a mother to newborn transmission, particularly of HPV 6 and 11, which causes respiratory or laryngeal papillomatosis in the newborn. So that is also an acquisition or a time that you can acquire HPV. So let's look at the lifetime, or let's put this risk into perspective. And why I do this is, if you look at the bottom there, the risk of breast cancer for a woman who takes hormone replacement treatment is about 1.3. So everybody is terrified of hormone replacement therapy, and we allow women to have terrible hot flushes and the symptoms of menopause because of the fear of breast cancer. Yet the risk, in fact, is quite low compared to the risk if you have an HPV 16 persistently positive. Your risk is 434 times higher than the normal population for getting a cervical cancer. So, in fact, your risk is really high if you have persistent HPV 16. And also, if you smoke, for instance, if you smoke, your risk of getting a lung cancer is 8 times higher than the general population. So what are the other cancers that are caused by HPV? Well, it's not just cervical cancer. And in fact, HPV affects men, women, across the board. For instance, oropharyngeal cancers, 72% of them are HPV positive. as are anal cancers, 91% of anal cancers. So in the anus is like the cervix. It has a squamocolumnar junction and is particularly at risk of developing a squamous cell carcinoma. And that is also in men who have sex with men. They are at much higher risk of getting an anal HPV-related carcinoma. Penile cancer, thank God, is very low, the incidence, but most penile cancers that are around 63% of them will be HPV-related, as will vulval carcinomas. And there's certainly not 100% of cervical cancers. We believe that a lot of them lose their HPV DNA marker. We believe that 100% are caused by cervical cancer, but they are by HPV, but they are a small minority where we can't actually pick up the HPV when we look for it. So again, let's look at across the board. So if you look at HPV disease, it's a triangle. So in fact, in terms of genital warts, you know, genital warts are a massive problem to us here in South Africa. You know, we, particularly in our immunocompromised patients, they get recurrence of their warts. We see massive genital warts, which are really disfiguring when we treat them. And I worry about genital warts in our patients. It is underreported. There is no reporting system. And certainly we really struggle to get rid of them. So the base of the disease that's caused by HPV is cervical cancer and genital warts. And then you can see it goes right up where worldwide, globally, penile cancer is far less common. So, you know, a lot of my patients will say to me, I have HPV. I'm terrified of my partner getting a penile cancer. And I tell them, don't worry about your partner. Thank God, penile cancer is rare. And you can't treat HPV in males, but we can manage HPV disease in females. So I'm far more concerned, clearly because I'm a gynecologist, but I'm far more concerned about women's disease because of this preponderance of cervical cancer and genital warts that we see. So look again now at women alone. So if you look at the burden of disease, all of us will have HPV, but thank goodness a minority of us will develop cervical cancer. But we need to concentrate on these high-grade lesions and obviously on the cervical cancer. But we would like to get rid of this burden of disease at the bottom as well. So in South Africa, just some sobering statistics. Now, remember, these are stats now that are cervical cancers that are registered from histology. But there are many, many women, particularly women in the rural areas, even women in urban areas who will never get a biopsy or get to a healthcare practitioner. And so I think it's very underestimated in terms of incidence. So annually in 2020, there were 5,870 cervical cancers, and it is the leading cause of death. We're talking about cancer death in women aged 15 to 44. I cannot understand why we don't walk for the cervix. Why don't we have days for cervical cancer? Why don't we walk for cervical cancer? Why isn't cervical cancer out there? Why aren't we talking about it? And I suspect it's because the poor cervix is in the vagina. And as soon as you say the word vagina, everybody's like, ooh, and then they don't want to, it's always got this sexual connotation. But, that cervix is a beautiful part of the anatomy that deserves protection. And we need to go out there and we need to spread the word that we can prevent this disease. So if you look at the age distribution of cervical cancer in 2020, look at the age distribution. The majority is in our working women, the women who hold the household together, the woman who is responsible for looking after children. Often, these are women that really are, I'm not saying that when you're young or older that you're not important to society, But these women have to take time out of work to get diagnosed, time out of work for their treatment. And it worries me that we are not managing our cervical cancer adequately. And we haven't done so over all these years. We really do not seem to be making a dent. Now, look at the difference between if you are HIV positive or HIV negative and you develop a cervical cancer. In fact, you develop a cervical cancer 10 years earlier than you do if you are HIV negative. So we need to take that into consideration when we're doing a screening program, that these women will present much earlier than our HIV negative women. So they took a look at the HPV prevalence in invasive cervical cancer. This was a study, it was a multi-center study that we were all part of. And have a look here, HPV 16 and 18 is the predominant two HPV types that cause cancer in South Africa, but then comes 35 and 45. And this is a little bit different to the rest of Europe or America, where the vaccines were formulated. And that is, for me, a slight worry. But HPV 16 and 18 certainly seems to be the predominant one when you're looking at in cervical cancer. So up to 70% of cervical cancers are caused by HPV 16 and 18. If you look at high-grade lesions, so these are high-grade SILs that you get on the pap smear. Again, 16 is the most prominent one, but 35 is up there. And if you have a look, here is 18 at 9.2%. So these are what we found in the HPV types when we looked at high-grade lesions. If you look at low-grade lesions, you'll see how that absolutely changes. So not all low-grade lesions turn into high-grade lesions. And we have to be careful about the over-treatment of low-grade lesions that are not necessarily caused by super high-risk HPV types, because I'll show you that that has consequences as well. So look again at this data. Again, 16, 18, 45, 35 is all up there. But again, just stressing 16 and 18 are the two HPV types that persist in a vagina and are difficult to clear. So let's talk about sex. So that is the commonest way that women acquire HPV. So in this article that was published in the South African Medical Journal, they looked at sexual debut in young women and in men, whether it be coerced or voluntary. And if you have a look here, look, 17-year-olds and 18-year-olds, 30 to 40% of them are sexually active. And that's why when we talk vaccine, we see that it was introduced before the age of 12. Because if you're looking for bang for your buck in trying to prevent HPV disease, you want to vaccinate young girls prior to sexual debut. But it is not necessary to be a virgin in order to get an HPV vaccine. The HPV vaccine is still very effective in women, even if they are sexually active prior to having a vaccination. So how do we control cervical cancer? So we can do primary prevention with vaccination, or we can do secondary prevention with screening. So in secondary prevention, we've already acquired our HPV disease. Now we need to treat it in order to prevent a cervical cancer. Whereas in primary prevention, we're trying to prevent the acquisition of HPV at the onset. And like I, explained to a lot of mothers, they go, my children are never going to have sex. Well, good luck on that score. We hope that one day they are going to have children, or if they want children, it's really up to them. But, they will be sexually active. So we need to protect our women. So the strategies, the World Health Organization recommends a comprehensive approach to cervical cancer prevention. We have to include screening and vaccination if we are going to get a comprehensive cover, and we're going to have a twin strategy to our approach in decreasing cervical cancer. So the good news about the cervix is that there's a natural history from infection to cervical cancer that allows us to screen women. So from the first time that you acquire HPV until you develop cervical cancer, in fact, there was a really bad study that was done in New Zealand where they did not believe that HPV caused cervical cancer. And they watched women who had cervical abnormalities, and they saw that from the incident infection, from the first time of infection to the time that they developed cancer was probably around about 10 years. But remember, I told you that in our HIV positive women, or in our immunocompromised women, those who have transplants, etc., that is much shorter. And they develop the cervical cancer much earlier. But cervical cancer has this prolonged time period that allows us to screen. But also remember that a lot of the low-grade lesions will go away. They will regress, and you'll never get a cervical cancer. So I always say there's a rule of 70. 70% of low grades will go away. 70% of cancers are caused by 16 and 18. So always remember the 70%. So what about screening with a pap smear? If you look at these countries on the left, and you see the intervals that they screen, 5 years here with Finland, every year in Germany, you can see that even when you screen annually in Germany, you still have a cervical cancer mortality that is higher, in fact, compared to an interval of 5 years in Finland. So don't believe that screening more often actually decreases your risk. It's actually about cover. You need to cover as many women as possible if you're going to make a difference in cervical cancer management. So how well are we doing in South Africa? This is very old data, and it's difficult to find new data. But if you look at the cervical screening coverage in South Africa, we are dismal. About 1.8% overall in 2003. We went up in 2006, and it certainly has got no better over the years. Look at this. Screening between 2002 and 2003, and I could not find any new data. It is really shocking. You need a coverage of round about 80% in order to decrease cervical cancer. So I did my gynae oncology. I spent 2 years in the UK, and I can tell you there, if you go to your GP, you have a pap smear, and if you don't pitch up at the time of your screening, you get a letter in the post. And if you don't pitch up for that one, almost the nurse comes to your house with a pap smear speculum. That was in those days. So you were actually followed up. But in fact, many of our women, even, in our nursing population, you ask who has had a pap smear, and you'll be absolutely astounded. How many of us as medical practitioners even go for our own cervical screening? I'm telling you, it's not as good as you think. And in fact, in the private sector, we overscreen. You get these women who come back year after year after year, all with the normal pap smear, who in fact probably didn't need that pap smear in the first place. So it really worries me that the number of women we're screening is extremely low. So what about our South African guidelines? Well, we have just updated them in February, about 2 weeks ago. We have not published what is going to happen, but these are our old guidelines from 2015. And we believe that you should be using primary HPV testing as your screen. And you should start at the age of 25. And if you are screening before the age of 25, you should preferably use liquid-based cytology and not HPV. And the reason for that is that before 25 years of age, you are far more likely to have an HPV 16 or 18 positive, but you are much more likely to get rid of it. And so you are unlikely to have any HPV-related disease, because I said to you, it's about persistence. And really, you could have had your first sexual debut, acquired your HPV 16, and in a year's time or 6 months, it's gone. So prior to 25, please do not do an HPV test. Then rather use liquid-based cytology, or question whether you should be doing a pap smear at all in that woman. In fact, we would say no, and that you would only be doing it if you saw a lesion or if you were worried about it. But unfortunately, we know that HPV testing is not yet freely available in the government sector. And in fact, even liquid cytology is not available in all centers. And they are still resorting to a dry slide. But most areas now have changed to liquid-based cytology. So what we say is that these are the old guidelines from 2015, and please watch this space. It is going to change. So as soon as it is published and verified, it will be out there for you to all get. So we want to initiate screening at the age of 25 or at diagnosis of HIV positivity. But let's think of this. If you are 15 years of age and you have your first HIV test for whatever reason and you are found to be HIV positive, that is not when you should be screening that young lady at such a young age. So in fact, the new guideline says 25 in terms of HIV negative or HIV positive. You end your screening at 65 in a high resource setting or 55 in a low resource setting. The interval, if you are doing an HPV test, if you are HIV negative, it will be every 10 years in a low resource, every 5 in a high resource, and HPV testing every 5 years if you are HIV positive in a low resource, or every 3 years in an HIV positive group. And we've done a lot of work with the medical aids in accepting primary HPV testing as your means of screening as opposed to cytology, because you are either HPV high risk positive or negative. And cytology, unfortunately, can be wrong in 40% of cases. So, cytology has lots of places where it goes wrong. Did you take it properly? Did you put it in the medium properly? Was it transported to the lab properly? Was the cytologist correct? Is the lab accredited? So there are many places where cytology can actually be wrong. So what we say is that you do an HPV test. If it is high risk HPV 16, 18, and 45, those patients should be going for colposcopy and treat if positive. If it is other high risk HPV positive, you would do a discriminatory test. And that's where the pap smear comes into being. If the pap smear is negative, you would repeat the test in a year. If the pap smear is positive, the person would go for colposcopy. And obviously, if they are HPV negative, then they would go back into the screening system. If you're looking at a low resource, it really doesn't change much at all, except they put in the age here that if you're over 35 and HPV 16 or 18 positive, you should be treated. If you are under 35 and medium risk, then you would be triaged according to the pap smear. And that triage probably should be cytology. So the key message for HPV testing is that the HPV tests vary and the use differs. And we advocate the use of HPV DNA testing and not messenger RNA, because messenger RNA is extremely expensive and it doesn't add much. There are many HPV tests that are available. And in fact, there is even self-testing now that is available for our patients to do. And we are slowly trying to validate those tests, because perhaps patients can screen themselves and they don't need to come to a health care practitioner for screening. There are many apps you can use if you don't remember when to send what to do. You can use the American Society of Colposcopy and Cervical Pathology or the British Society, and I really think we should be developing our own app, because these are way too complicated, involve way too many tests, and are way too expensive. But what about colposcopy? Well, colposcopy, I run an outpatient colposcopy unit, an academic outpatient colposcopy unit. If the lesion is a small lesion, we advocate the use of thermal ablation. Or we do a LETS under local. We don't take patients to theatre at all. We LETS all our patients in our private colpo unit. And in fact, most of the medical aids will pay for an outpatient LETS procedure, even if the person is on a hospital plan. And I think that's really important for us to encourage. The LETS procedure, however, has its own complications, and the delivery before 37 weeks increases by about 14%, and the need for cerclage about 11%. And that is particularly if you do a large LETS procedure in a patient who may not necessarily have needed one. And of course, there are incidences of premature rupture of membranes and low birth weight. And a cone knife biopsy increases your risk much more of premature delivery at 32 weeks. So I think it's important that we treat women, possibly not over-treat women. And, there's that fine weight between cervical cancer and over-treating. But I would say where I believe cervical cancer is endemic in our country, we need to treat if we are worried about it. So what about vaccination? These are the two things from the WHO. I love this one that says, don't let cervical cancer stop you. Get vaccinated as an adolescent and get screened as a mom. It's time to end cervical cancer. If you look at the Australian newspapers, they believe that Australia is on track to wipe out cervical cancer within 20 years. And they feel, and I'll show you the data, that HPV vaccination has been linked to a dramatic drop in cervical disease. So there are 3 vaccines available. There is the Merck or the MST Gardasil 4, which contains HPV 6 and 11, which covers genital warts, and HPV 16 and 18 for that 70% of cervical cancers. There is the GSK Cerverax, which is HPV 16 and 18. And now there is Gardasil 9, and I believe we'll have to ask MSD that it is soon to be here. And the Gardasil 9 contains 6 and 11 against genital warts, and then it contains 16, 18, 31, 33, 45, 52, and 58. I just wish that it contained 35 as well. That would have been my first love, but I'll take what I can get in order to protect women. So in Scotland, they introduced the vaccine in 2008, and they targeted girls between the age of 12 and 13 with a catch-up of girls up to age 18. And they managed to vaccinate 90% of the target group and 80% of the catch-up cohort. And they looked at the registries allowing for linking of vaccine status to screening. And look at this. There was a dramatic drop in SIN3 lesions, a nearly 60% drop in CIN3 lesions in women who were vaccinated and who entered their screening program at the age of 20. That's CIN3. So if you prevent CIN3, you will prevent cervical cancer. If you look, it was not just actually the HPV 16 and 18. They found that there was also some cross protection, and that cross protection was for HPV 31, 33, and 45. So even though they were vaccinating only against HPV 16 and 18, there was still a drop in other types of HPV-related SIM disease. So they believed that across from 2008 up to 2014, you will see there was a dramatic drop in the number of abnormal pap smears. There was a drop in the cervical cancer, and there was a drop in colposcopy. So that for me is really important. But look at this Australian data on genital warts. This is profound. So they introduced vaccination of the quadrivalent vaccine to females. And in fact, now in Australia, it's mandatory to vaccinate both men and women utilizing the vaccine that contains HPV 6 and 11. There was a 92% reduction in the HPV-related genital warts. And that, to me, is significant. If you compare that to the woman over the age of 30, this is the unvaccinated cohort, you start to see a drop-off, and that's probably because of herd immunity. So the more people you vaccinate, the less likely HPV 6 and 11 for genital warts is going to be out there, and therefore you will get what's called a herd immunity as well as a dramatic reduction in genital warts. They also have seen a dramatic reduction in the number of patients with high-grade lesions since the introduction of the vaccine. And they introduced the quadrivalent vaccine in late 2007. So when patients say to me, has this vaccine a new vaccine? Say certainly, like for instance, in places like Oz and in places like Scotland, it's been around since 2008. So there's good data to show its efficacy. So in the vaccinated pre-vaccine group, you'll see here was the incidence of cervical abnormalities, and look at the significant reduction in those that were fully vaccinated. But there's also been a reduction in those who were partially or unconfirmed in terms of their vaccination. So again, we're starting to see some herd immunity going through. So what about South Africa? How good are we doing? So in 2014, the vaccine was introduced into South Africa. If we look at our HPV coverage, in 2019, it was estimated that the first dose was given to 69% of young girls in government schools, and the second dose to 43%. But unfortunately, in 2020, the number of young girls that were covered with the vaccine dropped significantly. And obviously, COVID had a big part in this, but only 3% of young girls got the vaccine. So I want to conclude to say to you is that cervical cancer is caused by human papilloma vaccine. And vaccination, I think, is our answer, because we are not screening enough women. Even if women are getting screened, they are not coming back for their results. They are not getting their treatment. Colposcopy clinics are very long and limited, particularly in the government sector. And I would urge us that we need to come together, and summit leaders urge greater HPV vaccination in Africa in order for us to, and I believe we can eradicate cervical cancer. We need the will to, we need to understand that vaccination together with screening, we need to screen those women as well. But screening, unfortunately, is shocking, and it hasn't reached the woman like it should do. So let us begin with our young girls. And let us not forget that we do not have to have a virgin to vaccinate them. If a patient can afford to be vaccinated and is older, I would strongly urge that we vaccinate them. I've told my colleagues, we do a lot of transplants here at my hospital, and we vaccinate those patients as soon as they go onto the transplant list, because those patients also are particularly high risk, as are your patients who are on immune suppressants. So vaccinate, 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 screen, screen, screen. We can do this. We can decrease cervical cancer. Thank you.
Thank you very much, Doc. I like the ending there, vaccinate, vaccinate, screen, screen, screen. Don't you have lobbyists within your fraternity, the obstetricians and gynecologists, to lobby government? I mean, like you mentioned that they are not, government is not talking much about this, and then we see that there are other diseases where there's a lot of talk about prevention and screening. And so what about the association? Not much talk, not much lobbying that can...
There's been a lot of lobbying. Unfortunately, first of all, it is not a cheap vaccine. It is a vaccine that is introduced at the age of 12, which doesn't make it very easy. There is a lot of lobbying. I'm pleased to say that we're going back on track to give the vaccine again. Unfortunately, I think it's been moved from national to what do you call it? Each area is in charge of their own vaccine. Yeah, and Tando would be able to tell us more about that. But we are certainly trying to lobby. But like I say, the problem is as soon as you start talking cervix, vagina, everybody gets very anxious. And we need to demystify it, and we need to make it out there. That's what we should be doing. And, vaccinate, vaccinate, screen, 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 and come back for your screening result. Come back for your screening result. We need to actually be lobbying the public together with government.
Yeah, I like what you said about what happens in England, about the follow-up program that they have there. Perhaps also to mitigate against that, we should have something similar and part of public health to make sure that those who need to be screened or to do maybe just basic pap smears. I'm not sure if what's being done now.
You could link a cell phone number to an ID number and say, put it out there, everybody, who turns 35, have you had your cervical screening? Send an SMS. I mean, it can be done. It can be done. You know, every, even adolescents, have you had your HPV vaccine? You know, ask your mom or ask your caregiver or ask whoever. Do you understand?
Yes, yeah. No, I think it's a good idea. Thando, maybe you want to talk about the vaccines coming from the point of view of MSD, being one of the manufacturers. Just to share a few words.
Hi, Dr. Bella. I think in terms of vaccination, what I can say is that I do see quite a lot of questions in the chat. I think one of the biggest concerns from people is who is it for? So vaccines, I'll speak about the quadrivalent and the nanovalent vaccine. So the quadrivalent vaccine can be given to both girls and boys. And it can be given to the girls up until the age of 45. That would be the quadrivalent vaccine. And it can be given to boys up till the age of 26. And the nanovalent, which is the one that Dr. Smith spoke about, I don't know why my camera is doing that, lastly, can be given to both females and males with no age. There's no age cap for when it can be, from the ages of 9, and there is no cap of age to when you can actually give it, which is actually good because it takes into consideration all of the things that Dr. Smith spoke about, which is women who have already been exposed to HPV and the women who are also concerned about their partners being vaccinated. So both men and female can be vaccinated. I think, you know, she drives home the voice of women education, vaccination, not because those are the only genders who can be vaccinated. I think we try to talk about vaccination in the atmosphere or taking into consideration the World Health Organization's, drive for elimination of cervical cancer, since one of the diseases that HPV causes the most is cervical cancer. I mean, there's like 90% of cervical cancers are caused by HPV. So the link between HPV vaccination being very much associated with women is because of cervical cancer. But and just like Dr. Smith showed, there's other cancers that it can cause, which are also both in females and males. So there's vaccination for both females.
I think what's important. Can you hear me?
Yeah, we can hear you. Yeah.
So I think what's important is we have to think on a national, on a public health platform, and we can think on an individual platform. So on a public health platform, there's only so many rands that can go around. So if you want the bang for your buck, you vaccinate girls. But for instance, I vaccinated my son and my daughter. There's another disease caused by men, but that affects women. It's called pregnancy. And women take the contraception. Do you understand? If we're looking for bang for our buck, we need to vaccinate girls. But there is no doubt, if you can afford it, you should be vaccinating boys and girls, because particularly in, for instance, HIV positive males struggle with genital warts, men who have sex with men, they are actually the biggest vector. But if you look at burden of disease, it's in the female. So the other interesting data that is now emerged is that when you treat a woman, in other words, you do a LETS procedure for her HPV 16 or 18 disease, is to vaccinate those women. There's good data coming out of Spain now that it prevents reacquisition of the HPV. So in our colposcopy clinic, our private colposcopy clinic, we write a prescription for those women to get vaccinated to try and prevent recurrence.
Thanks a lot. I think you touched on males because there are questions about whether there's a vaccine for adult male and female about 40 years, but in particular about male. And that you were talking mainly about women, but also the males are also affected. But I think you've touched on that. Maybe just for more emphasis, you want to comment on that again?
So if I'm not, Chandra can correct me, but if I'm not mistaken, in the nanovalent vaccine, the one with 9 types, there isn't an age limit. But certainly in the quadrivalent, it's up to the age of 45 that you can vaccinate.
Okay, Tano?
Hi. Yes. So for the males, vaccination with the quadrivalent is allowed. It's indicated, but up to the age of 26. And for male, the cap, which is age 46, Dr. Smith, for quadrivalent is the females, and then for the males it's up to 26, and then the nanovalent has no cap for both females and males.
So we need to also, I mean, Tando won't like this, but, you know, there's possibly emerging data that a single shot will be enough. But at the moment, you know, the current guideline is that 2 vaccines prior to the age of 14, and after the age of 14, they need 3 shots. So that is what the current guideline is. So, you know, it's cheaper for you to vaccinate before the age of 14 than it is after 14. But yes, and you know, the other time that I strongly encourage women to get vaccinated is, you know, women who are now becoming, you know, divorced and they're going to enter the singles dating market again. You know, those women should really strongly think about protecting themselves from HPV. And those would be the women that I would also encourage to vaccinate.
Sure. Yeah, I think that's a message that we should be taking from this presentation and the discussions. Now, there's also a question that there is a very good evidence that even after one single dose HPV vaccine, there are long-term persistent levels of HPV neutralizing antibodies, thereby questioning the need for 2 or 3 doses. I think this comes from the International Papilloma Society. If we therefore can cover 69% of young girls with a single dose, we do not have proper coverage.
Well, I mean, ideally, so like I said to you, you know, the data at the moment is still for 2, but it is emerging that maybe 1 is enough. You know, certainly I see that, you know, ideally we would not like at least 90% of girls to be covered with vaccination. But yes, you know, up to now, we don't have really good data on managing on a single dose. But, you know, we need to get it out there and vaccinate.
Yeah, vaccinate. A 50-year-old HIV negative, perhaps negative, also HPV positive, other high risk. What's the way forward?
So if your pap smear is negative, other high risk positive, you'd repeat that, provided it's not 16, 18, or 45, you would repeat that pap smear in a year. If it is still high risk positive, that person needs a colposcopy biopsy.
Yeah, thanks. You've spoken about the, you know, when to vaccinate, but there's a question about the age limit. I think you did in your table that you showed that you did show the age limit for HPV vaccination.
Yeah, I see there's quite a few questions about how do you treat HPV. So HPV itself cannot be treated. It's a virus. There is no medication, cream, anything that actually treats HPV. You know, I tell patients the one thing you can do is stop smoking and vaping. You know, there's also now emerging data that vaping is just as bad as smoking. That's the only thing you can do to get rid of your own HPV. In other words, clear your HPV. So there's no cream or tablet or anything that gets rid of HPV.
Okay, I think that's quite clear. I hope that for the ones who ask this question, it comes right across. Can you comment on the disposable pap smear kits being introduced in some countries?
Yeah, so certainly it's not a disposable pap smear. It is self-HPV testing. So you would insert a tampon up in the vagina, a dry tampon in the vagina, and then send that to the laboratory. In some countries you can post it, but I'm not sure I would rely on that in South Africa. You probably need to drop it at the laboratory, and then you would get your HPV result. The disadvantage is the sensitivity or the specificity is slightly lower on self-collection compared to practitioner collection, but nevertheless is better than no collection whatsoever. So like I said, it's about 95% on practitioner collected. It probably drops down to about 87, 89, which is excellent. If a woman doesn't want to go for a pap smear, she can do her own HPV, or HPV testing with a practitioner. She can do her own HPV testing. The only thing that worries me is you need education to do that. Many women read Dr. Google when they've got an HPV 16, they're already dying of cervical cancer. I think you need to educate women that just because you've got the virus, it doesn't mean you have cancer. Far from it, and that's what worries me about self-collection. Self-collection needs to go with education.
Mm-hmm. Yeah, there's also two questions related to being HPV positive and whether there's a place for vaccination in such patients, and also comment about Dr. Karekula. She's a gynecologist, that she's seen patients being given HPV vaccine after an abnormal pap smear or positive high-risk for HPV results by GPs and some gynecologists. Is there any merit in this approach?
Okay, so how the vaccine works is it blocks the L1 receptor on your cell and it prevents integration of HPV. Remember, all viruses, in order to replicate, need to enter their host cell and then replicate within the nucleus. So the vaccine is not a treatment for the abnormal pap smear. I cannot stress that. I mean, I saw a patient with a cervical cancer the other day who told me her pap smear was abnormal. The GP vaccinated and off she went, believing she was cured. It is not a treatment. The only thing that the vaccine will do is perhaps prevent acquisition once you've treated the HPV with a LETs or thermal ablation or whatever. So it is not a treatment. Can you vaccinate somebody with a low-grade lesion? Yes, but it's not treating the low-grade lesion. So that is important. Vaccination is not a treatment. It is a prevention. So, you can't vaccinate somebody believing that their low-grade lesion is going to go away. The answer is no, it won't. It's already in the cell. It's already in the nucleus. It's already multiplying. So it's not going to treat that.
Yeah, I think you've just answered the question. Someone sent me a question directly, not on the chat that you can see, about vaccinating with someone with a low-grade infection, SGSIL, or on pap smear. Yeah, and then a 77-year-old hysterectomized with a Volt smear negative but HPV positive. Do you just do an annual pap smear?
Well, the question is, why did the 77-year-old have the hysterectomy to start with? And why are we doing a Volt smear on a 77-year-old when the guideline says you stop smearing at 65? So if you have a patient who had a hysterectomy for an abnormal pap smear or for a malignancy, they continue on their screening for life. But if you have a patient who now this 77-year-old has now had a pap smear and it shows a 16, but the pap smear is negative, theoretically, then you can just repeat the pap smear in this patient. And if she develops an abnormality, you can refer her for colposcopy of the vaginal vault. So it becomes really difficult now, because now you know this woman's got an HPV 16 in her vagina. Is it persistent, or is it just a transient infection? So I probably would repeat that in a year.
Sure. Thanks a lot. We getting close to the end. I see some people are. There's a question, Dr. Desai. I understand that we should do colposcopy on biopsy on patients with high grade PV.
So you should do a colposcopy and biopsy on anybody with a 16 or 18, regardless of what their pap smear says. But if there are other HPV type positive and their pap smear is negative, you would repeat that in a year. And if it's still positive, you will do a colpo biopsy. But you don't need to colpo everybody with a high risk HPV if their pap smear is negative. Only those that are 16 and 18 positive, regardless of their pap smear, they get a colpo biopsy. But the ones who are 16, who are non-16, non-18 positive, it would depend on their pap smear, and it would depend whether your pap smear was adequate. If your pap smear does not contain endocervical cells, then that person has had an inadequate pap smear, then you should be doing a colposcopy.
Okay. Is it true that younger patients are more likely to clear HPV?
Absolutely. That's why you must not do an HPV test before 25. You know, I always jokingly say, you know, when I get a 20-year-old who's been sent to me with an HPV 16 positive, I always joke with them and say, you're definitely getting more action than me, the old lady. And that's why you've probably got the HPV, but you are much more likely to get rid of it than I am, the old lady. So that's why we mustn't HPV test in a person under the age of 25.
Okay, thanks a lot. It looks like someone has just posted the management of HPV positive normal cytology. I think it looks like the message about when to treat, what to treat needs to be clarified for everyone, maybe just as a take-home message.
Take home, 16, 18, 45 positive, go to colpo. Other high-risk positive, look at the pap smear. Pap smear negative, repeat 1 year. Pap smear positive, go to colpo.
Okay. Well, fortunately, if people didn't hear, they can always go back to the YouTube recording and then listen to this, and as the take-home message that you've just mentioned just now. Yeah, I think we've come to the end. I'm going to ask, I know that time I'm abusing you tonight, just to do the closing remarks. And just to say thank you very much, Dr. Trudy, for agreeing to give this talk. Quite an exciting talk, and quite a high attendance for this evening. Great teacher that you are. It comes across.
Thank you so much, Dr. Wheeler. No, I would truly like to thank Trudy Smith for accepting my invitation, and I truly enjoyed your presentation. Like I said in the beginning, we have a teacher today, so it was reflecting. I've learned a lot, even myself, and I would like to thank the clinic's health group platform. This is a great work that you're doing, and we truly hope to collaborate with you in the future in healthcare worker awareness talks. So thank you, everyone, and I hope you learned a lot. Have a great night.
And go and vaccinate.
Definitely.
Yes.
we got the message. And it's not about COVID.
Have a good evening, and thank you for the invite.
Thanks for that. Quite an enjoyable session. Thank you very much. Thanks, everybody. Good night.
Bye.
Thanks, Kamu. Bye.